Good morning again. So, on our journey to abnormal psych, let's continue with chapter 7 on mood disorders. Okay, this is going to be, these group of disorders are going to be fairly commonly encountered. Yeah, should you pursue a career in mental health as a mental health practitioner, but certainly just as a, member of the general public. These disorders are fairly common. And without further ado, let's proceed. Alrighty then. So for today, we will be the mood disorders encompass um, the disorders related to depression and bipolar disorder. Okay. And we're going to see there are a number of subcategories or um, a number of types of um, depression disorders and a number of types of bipolar disorders. Alrighty. And clearly related to this topic is the issue of suicide. All right, so we'll get into some of the parameters of suicide, what it looks like, and how to address it. Okay, and just as a general matter, whenever you hear about depression as a mental health professional, if someone comes to your clinic and in an initial interview, they talk about being depressed as their presenting problem, a suicide assessment is a must. Okay. Um, when someone presents as being depressed, yeah, whether it's a major depression or a bipolar disorder, whatever the type of depression, yeah, you invariably have to, do an assessment for suicide. Okay. They go hand in hand, not all the time, but so frequently that the absence of a suicide assessment with the presentation of depression is really arguably professional negligence. Alrighty. So without further ado, we'll skip this stuff. So types of mood disorders. Let's go first. Let's first address a major depressive disorder or a major depression. Okay. Now, in order to meet the criteria for major depression, you need to have met five or more of the following symptoms. Yeah, a lot of these kind of make sense: depressed mood, diminished interest in things or taking pleasure from things you used to previously enjoy, like traveling or going to the beach or video games, whatever turns your crank doesn't anymore. There are a number of physical symptoms, yeah, weight loss, sleep problems, weight loss or gain, sleep problems, loss of energy, diminished sexual interest or energy, and also other subjective experiences of feelings of worthlessness and cognitive things, diminished concentration, and thought content focused on negative issues or morbid content like death. Yeah. Now, one of the things that is a hallmark of major depression are what's referred to as the vegetative or physical symptoms. Yeah, they include a change in eating with an increase or decrease in weight, sleep disturbance, and change in energy. Alrighty. Also related to that, change in libido or sexual interest and arousal. Alrighty. When you hear about those kinds of vegetative or physical symptoms, odds are you're dealing with a really serious depression, a major depression. Alrighty. Um, now, uh, the other thing that characterizes, in order to meet the criteria for major depressive disorder, alrighty, is besides meeting five out of or more of these nine criteria, at least one of the symptoms is either obviously depressed mood, or interesting enough, not depressed mood, right? It's the conjunction or loss of interest or pleasure in things that normally would have made you happy. Okay. And the symptoms, and clearly you can see if you have five or more of these, the odds are these symptoms cause distress. Yeah, they're upsetting to the individual or impairment in social occupational functioning. So these are the criteria general for major depressive disorder. Further, there's no manic or hypomanic episode. So what's meant by a manic episode? Okay, a manic mania, yeah, is characterized by it's like the opposite. Yeah, so swinging to the complete opposite of depression, incredibly high periods of elation. Yeah, or elevated mood. That's beyond what you would tip. What we're not talking about just feeling good or really positive. We're talking about an elevation of mood, feeling super energized, super positive. That swings in the opposite direction of being severely depressed. Alrighty, people in moments of mania might feel so elated, so energized, yeah, that they might think it might get to a delusional state, yeah, where they think they have the cure for cancer, or even to paranoid state, right? Their mood is so elevated, so energized, they start getting paranoid, and they may present other types of delusions, right? The first was a grandiose delusion, right? I have the cure to cancer. The other would be a paranoid delusion, like the KGB is after me, yeah. um, I recall years ago when I was in graduate school, I had a friend who had a friend when she was in college. Yeah, so 2 degrees of separation there. Who was an acquaintance of mine who had a manic episode during her first year in college. And one of the things that happened was when she had her manic episode, she was so completely paranoid, she was found hiding beneath kind of this statue in the middle of the university square, because people are trying to encourage her to get out from under the statue, but she was hiding beneath this statue as like kind of an archer, modern arch piece, where because she thought black government helicopters were flying above, monitoring her, um, and so yeah, it got to a psychotic level. Okay. And that's how bad mania can be. Alrighty. But again, it can show itself in really negative paranoid delusions or really grandiose positive delusions in the extreme. Yeah. But mania it's like depression, severe like lows. It's on a continuum. Yeah. So on the extreme, you might have psychotic symptoms with hallucinations or delusions, or it may be just someone so super energized that another one which is kind of extreme too. I had a student when in a manic episode, she could go for 2 or 3 days without sleeping. Yeah, we'll get to that in a moment. But for to be diagnosed as suffering from a major depressive disorder, there is no manic or hypomanic. Hypomanic means more of a reduced episode. Yeah, so not hypo, right? With the prefix hypo indicating less. So not an extreme mania, but a slightly lessened mania. So that maybe someone might be just going out on a shopping spree and spending $2,000 on their credit card without ever thinking, and then going on a cab ride for uh, the whole day and putting it on their card. Alrighty. Um, so that kind of elevated. It's also characterized by impulsivity, like I just mentioned with the shopping spree. Alrighty. Besides distress and decrease in social occupational functioning, you need to differentiate it from these other possible disorders. Okay. And one of the things that can be very tricky is distinguishing major depressive disorder, a major depression, from ordinary grief or sadness. Okay. And this gets back to the abnormality criteria. Yeah. And how every factor is on a continuum. Each of the factors, when determining if something is quote unquote abnormal, there are several factors in each of them on a continuum. And it can be a kind of a tricky judgment call. Yeah. Because if someone loses a spouse or someone has experiences the death of a child, yeah, there's clearly, in most instances, going to be a period of mourning. But how that mourning manifests itself, certainly will be a function of a number of things. Certainly, one being culture. Yeah. So, what is a normal period of mourning? Alrighty. Well, as a general matter, when someone presents these symptoms, in order to be diagnosable as suffering from major depressive disorder, yeah, you need to be presenting these symptoms for at least a 2-week period. Alrighty. Um, but but it gets kind of tricky. How was that 2 week period determined? Yeah. Who made that bright line test? Well, it's not super clear. Yeah. Um, but that's kind of a guideline. Okay. Now the reason why we're talking about major depression is because it's something you're going to encounter either personally, or as a mental health practitioner. Yeah. Lifetime prevalence is about 16%. Yeah. So the odds are, there's a 15% chance that someone at some point, that an individual at some point in their lives will suffer from a major depressive episode. Yeah. And at any given point, about 7% of the population suffers from a major depression. Yeah, and certainly this can be affected by context. Yeah, during this period of the pandemic, these rates certainly have increased in terms of at a given time. Um, there's been a larger percentage of the population suffering from a major depression. Probably for us in this last year during the coronavirus, it's probably gone up to about 10, I believe, like 10, 11%. Yeah, at least. Okay. Generally, the rates of depressive symptoms are lower in children, but certainly children can suffer from depression as well. And this criteria that we just looked at are applicable. Okay. Um, Children can, the rate of depressive symptoms is about as high as with adults, but usually the severity of the symptoms aren't nearly as high. Okay, we'll also talk about how suicide is fairly rare among children. Yeah, when that actually suicide does tend to spike or start to increase. Okay. And then there are also some other demographics. Yeah, those born after 1970, women more than men tend to meet the criteria more frequently, about 2 to 3 times more frequently. But certainly that may be a function of culture and gender role expectations, in particular in terms of expressing or reporting symptoms. Yeah, just generally, men are poorer at reporting um, symptoms, both psychological as well as physical. Alrighty, and probably it's to women's benefit um, in terms of health to lean on the side of reporting things. Yeah, no big surprise why women tend to outlive men by about in the U.S. by about 7 years. Yeah, it's that tendency or a greater inclination to report negative psychological as well as physical symptoms. Yeah, and it's probably to men's detriment that they don't. Now, the course of a major depressive episode, yeah, if left untreated, yeah, in most cases, major depressive episodes last about 3 months, and then the symptoms just kind of wane, dissipate on their own. Okay, that's not to say that people just kind of muscle up and motor it and don't take any treatment, because a major depressive episode is serious, especially in light of the fact that suicide is often goes hand in hand with depression. Okay, so it should be treated. The other thing that's been discovered in the last decade or so is that the earlier and that a major depression is detected and treated, yeah, with both psychological and biological interventions, yeah, the greater the reduced likelihood of there is a reduced likelihood that the individual will re-experience another major depressive episode. But if left untreated, there's an increased risk of experiencing another major depressive episode. Okay, you can kind of analogize it to having a heart attack. Yeah, if someone has a heart attack and then they have that first heart attack and then they're rushed to the hospital. If they experience the heart attack as opposed to having some initial symptoms, and then before a full blown heart attack it's treated, yeah, you really do decrease the risk of a subsequent heart attack if you get it early on before a full blown heart attack. Yeah, it's I'm oversimplifying, but it's something about the kind of the number that a heart attack really does on the heart, reduce increasing the likelihood of a future heart attack. Certainly, if you have another second full blown heart attack, you increase the likelihood of a third, and so on. But if you can catch these things when you get some initial signs before it becomes a full blown heart attack, you really do reduce the likelihood or the risk of a future heart attack. Yeah. Same thing with a major depressive episode. If things are initially starting to feel bad, if you catch it before you start having a lot of the other symptoms of the major depression, you can really reduce the likelihood of another major depressive episode. Yeah, it's really like if it's left untreated, it kind of does a number on the brain, whereas the brain is now more susceptible to another major depression. Okay, we'll kind of skip this. Let's talk about another type of diagnosed persistent depressive disorder. Okay, it was formerly known as dysthymia. I like dysthymia; it's kind of a nice word, but it's been changed to. I think it actually describes the situation more accurately. Dysthymia is like, okay, well, what is that? You ask the average person in the general public, they're gonna go, I don't know what dysthymia is. But persistent depressive disorder, I have to admit, it is clearer on its face what that represents. It represents a depressed mood that lasts for about 2 years, okay, and is never absent for more than 2 months. Okay, so we're talking about a fairly persistent, consistent state of being depressed for a long period of time, for 2 years. Yeah, so keep in mind, 2 year period. You gotta uh, someone needs to have shown depressive symptoms for a pretty long period of time, and it can be absent for short periods but never for more than 2 months. Yeah, if it's more than 2 months, then they're probably different major depressive episodes. Alrighty, so the idea, well, previously the term dysthymia it was meant to imply that the depressive symptoms is a function of personality. Yeah, so it's kind of a personality style. So you would refer to someone as being dysthymic. Yeah. Um, and maybe that's in part why the diagnosis, the name of the diagnosis or label, this really sounds like a label, was changed to persistent depressive disorder. And I have to say, this is one of the changes, I think, among a number of changes, I think it was a good change. Yeah, it took away the idea that it was some personality construct and more, just could be biological, could be circumstantial. The bottom line is that observationally speaking, it's persistent. Yeah, and the idea with the DSM is that it's a theoretical. Yeah, but the thymia kind of implied a theory, and the theory was that it was due to some personality style or construct. And here, persistent depressive disorder is we don't know. All we know is that observationally, it's fairly constant. Yeah. Now, related to persistent depressive disorder is this concept of a double depression. Oof, what is that? Okay. What isn't something nice like a double latte? Okay, now that's a nice thing. Double depression, not a nice thing. Okay, the idea of a double depression, and it's really a painful thing for someone to experience, and something to look out for if you're a mental health practitioner, is when someone suffers from persistent depressive disorder. And while having a persistent depressive disorder, yeah, they also experience an increase in depressive symptoms suggestive that of a major depression. Okay, so it's like so it's one of this persistent kind of um, low uh, um, low grade depression, but now it's spiked up. All right. So it seems to be a separate episode. Okay. You still diagnose them as suffering from persistent depressive disorder. This is an unofficial kind of a descriptor of what someone with persistent depressive disorder may experience. Okay. So I want to say double depression is not a diagnosis, but it's something that someone with persistent depressive disorder may experience. All righty. Having this low grade depression with these spikes of severe depressive symptoms. Right. Just like with major depression, someone has to also, this has to cause some distress, which more likely than not it will, or a decrease in social occupational functioning. Yeah. So again, they could be doing fine at work or with friends, but because of the conjunction or, as long as it distresses them, causes them pain, and they're suffering from this, you can diagnose them. Alrighty. And you want to distinguish it again from these possible alternative diagnoses. Alrighty, let's talk about bipolar disorder. And there are actually two subtypes. Alrighty, but generally, what is bipolar disorder? Bipolar disorder is characterized by mood swings between severe depression and elevated mood. Okay, which can be characterized by grandiosity, impulsivity, yeah, extremely happy mood, or extremely paranoid. And it could be very negative too, but it's elevated in that the person is energized, right? In the extreme case, as I mentioned before, they could be experiencing psychotic symptoms, hallucinations, or delusions. Um, it can affect them physically, where they're so energized they require no sleep for 2 or 3 days. You know, um, and it's really this emotional roller coaster, yeah, where they're severely depressed and they have manic episodes, so going super low with, and it could be so severe that they are experiencing suicidal thoughts as well as these manic periods of elevation. Yeah. The manic episodes tend to last anywhere between several weeks to a few weeks to several months. Alrighty, and then but when they dip, it can be incredibly severe. Alrighty. Now, there are two types, bipolar 1 and bipolar 2. You can think bipolar 1, numero uno, is when this applies to people who have at least one full manic episode, okay? And let's see, at some point in their lives, plus any number of hypomanic, in other words, reduced manic and a major depressive episode. Alrighty. And full manic meaning the extreme type of elevation that I described earlier. Yeah, which may include psychotic symptoms and so on. Okay. And what we see is extreme mood swings between, again, manic episodes and major depression. All right. Now, this is a good point to mention. One of the things that's often a challenge with a bipolar disorder is um, treating someone because not so much because of this fear depression. That certainly is people want to get away from pain and suffering. Yeah, that's an obvious one. That's a motivator. But the thing that makes it difficult to treat someone with bipolar disorder, yeah, is are the elevated moods. Yeah, because they're so rewarding for many people who experience that. Yeah. I mentioned to you a student who, when in her full manic episode, she could go without sleeping for 2 or 3 days. And during that period, she could do tons of reading, do a lot of writing, do a lot of schoolwork. She was incredibly productive. Yeah. And that's something that, I think many of us kind of wish we could do, right? Have no sleep and be equally, if not more productive than usual. And people can feel so elated, so good. Yeah. It's like being on a legal substance, yeah, where your mood is so elevated, you're so happy, that's a feeling that many individuals who suffer from bipolar disorder don't want to lose. Just as a severe depression is something that really motivates you, you want to lose that, right? That pain and suffering. It's the complete opposite, right? You're so energized, so elevated that's something that is painful to lose. There was another gentleman, that I worked with when I was in graduate school. When he would have manic episodes, similarly, he can go for a day or two without sleeping. But during that time, he was like a salesman. He could do tons of sales during that time, constantly. So when he was awake, he had the energy, and he could make us. And he was, he had easily, could make a six-figure salary in a given year. But when he was medicated, and that stabilized his mood, right? So he didn't have the elevations nor the severe mood, but it was more stabilized. Yeah, he, according to him, felt like a mortal, and so he would sleep whatever 8, 9 hours, and then have regular waking hours. But then he didn't have the energy to put in the same sales. So salary ended up making a average, 5-figure salary. And that kind of got him down. And he missed that. And he struggled with that. Yeah. So with that female student, with this female student, with the male salesperson, there were struggles with staying with treatment, and that's one of the challenges. Yeah, with treating someone who's suffering from bipolar disorder. And bipolar 2 disorder is kind of the reduced, right? So not numero uno, but the second. And it applies to people who have had more hypomanic episodes, yeah, reduced mania. So it may not be the extreme elevation and good mood and energy as characterized, or with as which may also be associated with psychotic symptom. It's more reduced where, they still feel elevated, but they may not have a delusion that they're going to cure cancer. They may not have that thing where they can't sleep for where they can go without sleep for 2 or 3 days. Yeah, it's elevated. They feel kind of high, but it's not that extreme level of high. Yeah, and at least one major depressive episode, okay, without having a full blown manic episode. Writing in both cases, um, you have they have to also be distressed or experiencing social occupational a decrease in social occupational functioning. Okay, and what is a cyclothymic disorder? Okay, interesting enough, this label still stayed even though it remains, although dysthymia was changed to persistent depressive disorder. Cyclothymic disorder is kind of like the bipolar disorder version of dysthymia. Yeah, it's when someone has demonstrated both hypomanic, not full mania, but hypomanic and depressive symptoms for at least a 2 year, again, matching over 2 year period. And they're never without the symptoms for more than 1 or 2 months. Okay. So it's just the bipolar version of dysthymia. All right. It's thought of as more characterological um, kind of bipolar disorder. Okay, more like a personality style. Okay, although very often those who suffer from cyclothymic disorder, they're put on similar medications as those who suffer from bipolar disorder too. Okay, alrighty. So, what is the etiology? What are some of the causative factors that we understand regarding depression? Well, with that, let me pause for a moment and I'll be right back. Okay, everybody, thanks for your patience. And with that, let's continue. So, in terms of some of the our understanding of the causative factors of depression and bipolar disorder, there certainly are biological causes. Yeah, and the research supports that. There seems to be a genetic contribution. Yeah, this is found through family studies. Yeah, it tends to run in families, and particularly bipolar disorder and twin adoption studies support that as well. Yeah. Now, what neurotransmitters tend to be most implicated? They include norepinephrine and serotonin. Yeah, norepinephrine associated with arousal, and serotonin with sleep, eating, and sexual behavior modulation. Alrighty. Now, it's not so much the case that there's with depression, diminishment of norepinephrine or serotonin. There may be, but more likely it seems to be an issue with the neurotransmitter receptors. Yeah, either in irregularities with the number of receptors that can pick up these neurotransmitters, abnormalities in the sensitivity of receptors. So not the number, but to what extent they can they're sensitive to these two particular chemicals and some other and or other irregularities in how these chemicals bind to the receptors. Okay, there seems to be also some evidence of brain structural differences with possible structural problems with the prefrontal cortex, with organization and planning, as well as the limbic system, yeah, which is involved in emotional regulation. And as mentioned before, bipolar disorder has a strong genetic component. Yeah. So if you have a parent with, bipolar disorder, the risk for the child having bipolar disorder is very high, anywhere upwards to about 50%. Now, there are clearly psychological factors related with uh, mood disorders. Okay, certainly stressful experiences. Yeah, like losing a job, getting divorced, um, going through a pandemic. can be a risk factor for major depressive disorder or recurrence of MDD, major depressive disorder. So certainly stressful events, are very common bases or causative factors for major depression. Yeah. Um, there are also, as discussed in the text psychodynamic, right? Reasons and psychodynamic theories arise or were influenced by original Freudian psychoanalytic theories. And with from psychodynamic theories, the idea of depression is that it's anger turned inwards. Yeah. So if an individual is feeling anger towards society or their parents or their spouse, yeah, because of cultural factors or pressures, they can't express that anger. So they turn it inwards, yeah, towards themselves. And that's the way that they can manifest their anger towards their loved ones or society or whatever the case may be. With bipolar disorder, the psychodynamic explanation is that it's a shifting of the dominance of the ego as well as the superego. Yeah. Um, so when the ego uh, dominates, you have an elevation of mood, and when the superego dominates, right, and it's pounding, is exerting pressure on the ego, right, the person's more likely to be depressed, right, because they're not meeting societal standards. And clearly, there's a lot of empirical support for cognitive behavioral components to depression. From a more behavioral standpoint, depression is just, well, simply, but certainly still, hard to work with and hard to change, but is simply a matter of um, um, learning behaviors that don't bring about positive reinforcement. Yeah. So someone has learned a certain repertoire or pattern of behaviors that really don't work so well in terms of getting them what they want. Yeah, good grades or meeting people or dating or whatever the case may be. And because of the lack of positive reinforcement, yeah, they experience depression. Okay. And the depression leads to inactivity, right? Because when we're feeling down, we're less likely to exert time and effort to studying or time and effort to make friends or to go out and meet people to date, right? And then that inactivity, right, produces kind of this vicious cycle where we get less reinforced and then that makes us depressed and so on. From the cognitive therapies like Beck and Ellis, yeah, and here we're going to focus a little more on Beck. They've certainly contributed in terms of our understanding, and there's tons of data supporting the cognitive component to depression. Yeah, that those who are depressed, one example, demonstrate what Beck has described as a cognitive triad. Yeah, that there are certain grouping of beliefs about ourself, the world, and the future, and a bunch of automatic thoughts related to that that tend to be of a negative valence, yeah, where we demonstrate a lot of the cognitive distortions as discussed in the text, but now they relate to those cognitive distortions that lead to negative affect, concern, beliefs about the automatic thoughts about the self, our performance, the world, how fair the world is, and the future in terms of hope. Yeah, and certainly hope is that is one of the I didn't mention this earlier, but when it comes to depression, yeah, what hopelessness is one of those symptoms you really want to look out for. Okay, it certainly is a critical symptom with depression. Yeah, when people have a belief that they can't change things, yeah, that they are destined to be unhappy or destined to not get any positive reinforcement. What's an example? Is if someone breaks up with their boyfriend or girlfriend and they truly believe they will never meet anyone else, or if they do, it's never going to be as good as this person that they just broke up with. Yeah. So that feeling and belief that, sometimes they're one and the same, of hopelessness can certainly contribute to depression. And it's clear that if someone thinks differently, yeah, if they think like, well, I broke up with this person, I'm sad, I'm going to miss them, they were very unique, but I know I can meet someone else who's unique in another way. You're less likely to feel depressed. You may be sad, and that's a reasonable feeling. That's That's something you should be feeling when you break up with someone you've been dating for a while. If you don't feel sad, then probably something broken with you. Um, but if you're, so it's reasonable to be sad. Yeah. It's not unreasonable to be depressed, but it's understandable, right? It's common to feel sad. You should be feeling sad when you lose a relationship, right? That's understandable. But the thing, and it's not to say it's ununderstandable, but sometimes we take it even further and we say, well, it is ununderstandable. We can understand it, I mean, logically, but the logic breaks down when we say, we will never meet someone ever, ever again, never make a new friend, never get another job, never get a good grade. And those are the kinds of thoughts that contribute to depression, those kinds of errors in logic. Another cognitive behavioral framework is that of learned helplessness. Yeah, it's related to reinforcement. Yeah, but this is where if you observe in your client that they've experienced a series of events where they just seem to not be able to control their circumstances with work, with friends, with their love life. Yeah. And when someone experiences a number of events where they tried to control it, but they were just unable to, you're likely to experience helplessness. And logically you would, right? Understandably you would, and then but that helplessness, right, will contribute to feelings of hopelessness and then decreased mood. Learned helplessness is also referred to a certain cognitive style, the way we attribute, the causes of things. Right? So, are things due to, for example, ourselves, or is it due to external factors? Yeah. So, is the fact that, let's just say I don't have as many friends, I'm all by myself playing video games, right? Is it something which I can, change, or it's due to me, or is it due to external? Like this is just life. This is the situation phenomenon of friendships and me. This outside phenomenon which I can't control. Yeah. Is it stable or unstable? Yeah. So are you saying to yourself, right, I will never have friends. This is just me. This is my character. It's my, and you can see this is why it's sometimes tricky when you work with constructs like personality, that this is just me. I can't change it. Or is it unstable? It's like, um, uh, having or not having friends may be due to a number of causes that are out of my control, but that, for now, but it's subject to change. Yeah. And global versus specific. Yeah. So if you get a bad grade, right, you get a F on your history paper, and you go, oh no, well, I'm just stupid. I will fail in college. I will fail in life. Or do you say, look, I failed on this paper. Um, Specific situation, I may do better on the next paper. Or I'll certainly, even worst case scenario, fail out of this class. I'll do better in other classes, and so on. Yeah. So it's helpful to think about or examine our attributional style. What do we attribute circumstances to? Yeah. And what is the logic of the way, if it's causing us to be depressed, what is the logic of that, or the evidence to support that attributional style, which is making us depressed? Okay. And at present, we really don't have a very good, strong model for a psychological model for bipolar disorder. Yeah. Um, the thing that really best explains it is the biological. And no small surprise, biological interventions tend to be more effective. Now, that's not to say that someone who suffers from bipolar disorder may also benefit from psychological treatment, therapy, to help them deal with the biologically driven disorder, right? Because even if you have even if you know it's principally biologically driven and can be resolved in large part by medication, right? Clearly, there will be things that one will be doing um, behaviorally that may not be so adaptive, yeah, that arises from that disorder. And it takes time to treat that disorder biologically too. So all of the behavioral kind of consequences of having bipolar disorder certainly can benefit from psychological treatment. In terms of the treatment, oh, let me take a little tea break. Yeah, no, it's not always Red Bull. Thank you. When it comes to the depression, in terms of the biological treatments, there are four families or generations of antidepressants: the tricyclic MA monoamine oxidate inhibitors and the selective serotonin reuptake inhibitors and the serotonin norepinephrine reuptake inhibitors. Alrighty, the first two tend to be the older generation of antidepressants, which can be quite effective, but are associated with a lot of negative symptoms like weight gain or loss, usually weight gain, decrease in libido, um, dry mouth, and so on. Whereas the latter two, SSRIs and SNRIs, are quite effective, but with little to no negative side effects. Okay, but why do we still keep the first two generations up on our list? Well, it's because they are still frequently used. Alrighty, because despite the advantages of the latter two generation of antidepressants, yeah, they don't work for everybody. Yeah, or they work in combination with one of the two earlier generation antidepressants. Okay. As an aside, um, when it comes to this, is usually in terms of the biological treatments. Yeah, usually the first plan of attack is to try an antidepressant. Yeah, usually a latter generation one, and then maybe two, or then maybe using some combination of a latter generation with an early generation or an early generation antidepressant. Yeah. It's also a process of finding the right dosage for each individual. Alrighty. And as you can kind of pick up, sometimes, yeah, this can be a process of experimentation, which can sometimes last for a few or several months for some individuals, which can be very stressful because they're still going through their depression. And hence, the benefit of doing psychological treatments concurrent with the biological. Plus, this period of experimentation can really kind of wreak havoc on on an individual's mood, right? As they, first of all, on their mood, but also second in terms of also then struggling with negative side effects and so on. Alrighty. Some people luck out, many people luck out with the first medication and the first dosage. Yeah, one med, an SNRI, a certain dosage, boom, it's effective in a few days. And they already are starting to see it. And that's the wonderful thing about a lot of these antidepressants. Within a few days, you can already start seeing some benefits, right? They're starting to already feel their mood elevating. Yeah, not being as severely low. As an aside, too, uh, now, there are some people who get prescribed an antidepressant and that's all they want and that's all they need for themselves. Yeah. You don't have to do biological as well as psychological interventions. Alrighty. That said, most people, and regrettably, I can't cite a study offhand, but just more anecdotally, many people will report that the antidepressant helps them. It increased their mood, right? They weren't as severely depressed, but usually they won't say that that the depression has completely disappeared, that they are still mildly depressed. Yeah. And the odds are it's because, in part, right, although there's a biological component, there are clearly things around them that were happening as well. Maybe they just broke up with their boyfriend or girlfriend, and then they got depressed, and they had a genetic predisposition for major depression, and then receiving a medication afterwards helped. But clearly, maybe there's something about breaking up with the boyfriend or girlfriend that was particularly difficult. Yeah. Whereby the psychological treatment could be effective. Yeah. So very often people will report that the antidepressants are helpful, but that they're not things that's going to make them or anybody else a grinning idiot, right? It's not that it drugs you up and now you're completely dependent emotionally on the antidepressant. Some people may, but as a general matter, people don't. It kind of helps them. It allows them. It's kind of let's just say not a crutch. That seems like like an excuse. It seems like it's something that's very helpful to help them get through a rough patch. Yeah, and most people tend to say that they don't want to be on antidepressants for the rest of their lives, and you don't have to be, right? It's not uncommon for people to be off an antidepressant after a year or two, yeah, or even less, depending on the circumstances. Alrighty. Other types of biological interventions, ECT, electroconvulsive therapy. Okay. Now, this usually isn't the first go to. The first go to will be some medication or medications and dosages. Yeah. But if they don't work after a reasonable period of time, maybe after trying combinations of medications for a few or several months, also factoring in the severity of the depression. Okay. If after going through a period of experimentation for a few several months and the person is severely depressed and suicidal, yeah, um, a, a psychiatrist may consider going through having the patient go through a regimen of ECT, which traditionally referred to as shock therapy. Alrighty, where a certain level of electricity, it really comes down to a certain level of electricity being applied to. Usually, it's one as opposed to both sides of one hemisphere versus both hemispheres of the brain to induce a seizure. Okay, the patient is usually anesthetized, so they are asleep when this happens. The treatment is relatively brief. Yeah, it's a few administrations of electricity, usually to one side, one hemisphere of the brain. And at this point in terms of the art and of not the art but the science of ECT, dosages are such that they can induce a mild seizure without causing severe brain damage or memory loss temporary memory loss for recent events may occur, but it's usually fairly temporary. Yeah. um, and but ECT can be incredibly effective. Yeah. So in situations where the meds don't make a dent, yeah, ECT can be incredibly effective. All righty. And that's why now it's a common go-to treatment when, as mentioned before, medications don't work. Now, with bipolar disorder, the common medications include lithium carbonate, that's still fairly commonly administered, as well as other anticonvulsant drugs like Tegretol, Depakote, and Lamictal. Alrighty, and again, like with major depressive episodes, sometimes it's a matter of going through different meds at different dosages. Um, but usually, medications can lead to a significant, if not almost complete, remittance of bipolar symptoms. Yeah. The thing with bipolar disorder, though, is once someone finds the right medication or combination of medications, the idea is that the condition is chronic and they have to remain on the meds. Yeah, it is possible after a period of time to consider uh, reducing the person from the medication, right? Tapering them off the medication. But as a general matter, it's seen as a chronic condition which needs continual medication use. Alrighty then, let's talk about the matter of suicide. And with that, I'm just going to pause for a moment, take a quick break here. Okay, folks, thanks. And let us get back to our topic and suicide. Alrighty. Um, you're probably all well familiar with the prevalence of suicide. In a study in 2006, little dated here, it accounted for about 500,000 emergency room visits. That's probably an underestimate now, especially during the coronavirus pandemic. And more than 30,000 people per year, about that a number, and I think it's still the same now, commit suicide. 30,000. All righty. Um, and sadly, I think for all of us, myself, for those of you, audience members, we can all think of family members or friends or acquaintances who may have committed suicide. Yeah, it's really something that it's like a heart attack or cancer. There's hardly a person who doesn't know someone. Yeah, with some degree of relation that had committed suicide. Just like everyone knows someone who had a heart attack or has had cancer. It's that prevalent. As mentioned before, it's very rare among children. It really tends to increase, contrary to the stereotype that adolescents are the biggest attempters and committers of suicide. It certainly the attempts and commissions increase around adolescence, but it really starts to spike around young adulthood, about the period of 25 to 34 when people have left college and are getting married and entering the workforce and so on. And you can imagine, right, the impact of those significant stressors. The suicide rates tend to increase, particularly among men. Yeah, men commit suicide 3 times as much as women. Yeah, women may attempt 3 to 4 times as much as men, but men are far more successful at killing it themselves. Alrighty, and men over 65 have the highest rate of suicide. So we can see the suicide rates here, right? Very low, right? Um, Among children, yeah. But when you adolescents, that's where you get a big increase, yeah. But the biggest increase where occurs about 20 to 24 and 25 and onward, yeah. So this is where we start seeing it really elevated, where the it starts, starting to peak at about middle age, right, or latter part of being middle age, 45 to 54, right? Tends to start dipping after that. And we can see around the mid 60s, right? It kind of being lower, um, right? We're getting a big kind of dip here. But then at about 74, and then when you start getting to your 80s, and this is where it kind of peaks again. Okay. Interesting enough, as an aside, um, you know, there have been a number of studies that have shown that marital satisfaction is actually at its greatest around here. Yeah, about age 65, not when you're first married. Yeah. Um, but actually, when you look at the suicide rates, they're about equivalent. Yeah. But it's not that, suicide rates increase, and then they continue to increase, right? It starts dipping again and it gets back to when we were 25 and so on. All righty. And and there are a number of factors why marital satisfaction is often the highest when we're in our mid 60s. And that's something we can chat about when we meet face to face or on Zoom. In terms of ethnicity, there are some interesting findings. In particular, the rates of suicides tend to be higher among whites as opposed to non-white groups. Yeah, so we look at non-white Hispanics, not actually non-Hispanic whites. Yeah, so Caucasians, right? Fairly high, the rate per 100,000. Yeah, but then when you get to non-Hispanic blacks, big dip. Hispanics, big dip. Native American cells, right? Just as high, if not higher, than for Caucasians or whites. Yeah. And you have this play out similarly with other um, indigenous people from like Hawaii and Alaska. Yeah. And that's maybe something we can chat about too the next time we meet face to face or on Zoom. Yeah, maybe. And sadly, maybe no, it's not a surprise. Yeah, that the suicide rates for indigenous people are that high. Okay, and then it dips down again for Asian and Pacific Islanders. Alrighty, and you can see, right, the rates for males are far higher than for females. Another very concerning phenomenon is what's occurring with Gen Z. Yeah, in CDC injury reports from 96 to 2016, yeah, the suicide rate per 100,000, yeah, by sex for ages 50 to 19. And as a general matter, as you may be familiar, Gen Z is characterized by those born in 1995 and later. Yeah, so it's capturing that demographic here. And for that demographic, yeah, from 96 to 2016, yeah, suicide, yeah, the commission of suicide has been up for males up by about 25%, yeah, during this period. And for females, it's been up by 70%. Yeah. Males still, per 100,000, commit suicide more than females. But what's particularly concerning for Gen Z is that how it's been up 25% for males and up 70% for females since 2001. So from here to here, 70% increase. Yeah. Whereas for here to here, it's been about a 25% increase. Okay. I'm sorry, since here, 25% increase, and since here, yeah, about since about here, 70% increase. Okay. Why is that the case? Well, that's again something we can discuss when we meet face to face or via Zoom. Now, what are some of the symptoms, things to look out for in terms of signs of suicide? Yeah, well, a lot of these you're probably well familiar. Now, as I mentioned before, if someone demonstrates hopelessness, yeah, and if they say things where it sounds like where they're expressing that they've given up, in terms of work or school or relationships, yeah, um, that's one big tell. Alrighty. And again, people can be sad, but they know logically they could meet someone else, they could do better in school later, they could get another job. But people who say it will never happen, that's a red flag. Okay. Certainly, if someone's telling someone of suicidal kinds of thoughts, right? It could be very passive suicidal thoughts, such as "I wish I were dead," or "Wouldn't it be nice to be dead? It must be nice to be in heaven. There's no stress." All that kind of stuff. Yeah. Two, thinking about how they would do it. Talking about people who've committed suicide and so on, and the reasons they committed suicide. Disposing of possessions, giving away things, closing financial matters like making a will, um, not or paying debts, or closing other matters like buying a cemetery plot. Um, if just out of the well, not out of the blue, right? They're depressed and they talk about doing stuff like this. you know at a certain age, it's certainly reasonable to write your will, and certainly probably when you start acquiring property, right? You have a car, you purchased a home, and so on, you have children. That's a darn good, you should be writing a will. But if someone writes it for reasons aside from that, yeah, if they purchase it, at a certain point in life, right, you should consider a cemetery plot, yeah, or how you want your remains to be disposed of sounds like the trash. How whether you want to be cremated or buried, all that kind of, what kind of, how you want your death managed. At some point in life, latter part of life, it's reasonable and you should be thinking about that. It's different when it's doesn't follow that developmental path. Yeah, when you're not elderly, but you're thinking of doing stuff like that. That could be a tell. Recent loss, and particularly suicide. Yeah, it's now there are a number of reasons why people want to kill themselves. Yeah, it could be loss of a job. Yeah, that they worked at for 20 years. Uh, could be, but I'll tell you, it could be a loss of a job, financial circumstance, right? Incredible financial loss. Um, so it certainly could be finances or work. Obviously, finances, that's a financial situation. But a very common one for people will be the loss of a relationship. Yeah, maybe death of a child, divorce, romantic relationship ending, and so on. Very common. Yeah. Um, if they talk about a lot of morbid content as well, and wishing for a peaceful state. So, in terms of assessing suicide, yeah, I'm just going to go over this roughly. But, with someone who's depressed, as I mentioned before, you should always conduct a suicide assessment, okay? Because they so often go hand in hand. And part of that assessment involves understanding what they're thinking, what their intention is, and if they have a plan. Alrighty. Now, first at the get go, um, when starting this discussion, yeah, um, it's absolutely fine to ask someone if they're having thoughts about killing themselves. Just ask them, "Are you thinking about killing yourself?" Alrighty. A lot of us resist being that direct with it. Alrighty. Um, and I'll tell you, I'm not aware of any good research on this, but I'm also not aware of any kind of situation where someone completely lost it when you ask them directly. All righty. They might be a little surprised, like if they aren't, but if they are, right, they, I'm hard pressed to think of a story where someone ran out of a room screaming because you asked them if they had thoughts about killing themselves, right? Now they may be upset because you're hitting it right on the head, what they're going through. But if they're not thinking of suicide, they'll tell you, right? I mean, that's overwhelmingly, that's usually what happens. You know, either you're on target to one degree or another, and people um, uh, might cry because you're addressing something that's very concerning, that they're scared about or they feel bad about, which they don't have to feel bad about. Um, or they're not, and then they'll tell you. So, my point being, don't be inhibited from asking directly. Yeah, you'll want to find out exactly what if they've been thinking. Yeah, and it can range from something not, something relatively benign and not a high risk, right? They've been thinking about how it'd be easier being dead, or nice to be in heaven with their family and not be stressed out anymore. But they're not thinking of suicide. To someone thinking, I think about it all the time, I can't take it anymore, and so on. Yeah, that kind of gets into intent. So, do they intend to do it? Yeah. So, someone might be thinking about it all. It's possible that they think about it a lot, but they will never do it. Yeah, they have no intention of doing it. Right? Maybe because they have kids, because they would hurt their family. It's against their religious beliefs. Whatever. That's for you to find out. What's influence, what is their intent, yeah, and what's influencing it, versus someone who says, yeah, I can do it at any moment, I've had it, I can't take it anymore, I'm going to do it. Alrighty. And some people can articulate that. Then the other thing you want to find out is if they have a plan. Yeah, so if they've had a lot of thoughts, if they intend to do it, have they figured out how they would do it? Yeah, it's one thing when someone says, I don't know how I would do it. It's scary to think about it, but I can't take it anymore. Something like that. So they don't have anything specific. But if they tell you something like, my dad owns a gun, I know how to get access to it. I know where the bullets are, and I know where I would point the gun. And I would do it when people aren't around, when the family's away. That's way more concerning. Okay. So these are the three areas you want to assess. And, it's not a hard rule in or rule out, yeah, in determining whether someone's a risk, right, imminent risk, right, that of killing themselves. Each of these factors are on a continuum. But the more, but the higher you are on each factor, yeah, the more likely the person's at imminent risk, meaning that they could do it at any moment, yeah, of committing suicide. Other things you want to consider, kind of pointed to it just a moment ago, if they have access to weapons, if they have any prior attempts. Yeah, prior attempts are a real predictor of a commission of suicide. Alrighty. Now, as an aside, there are also many people who attempt but don't actually commit suicide. But of those who've committed, there usually were prior attempts. Okay. And now other things to consider is also family background. Do they have family members who've attempted or committed suicide? Yeah. Other factors you want to consider: do they live with others? Yeah, multi generational family, immediate family, significant other, or do they live by themselves? Yeah, the living by oneself is certainly a risk factor, yeah, for committing suicide. Drug use is another thing you want to look out for, right? Because that relates to impulsivity. Alrighty. Um, and with that, that's all I have to say about suicide. Okay. Um, so with suicide, things to look out for, things to do, and if you determine that someone's at imminent risk, there are a number of ways to address it. Yeah. Um, as a general matter, so that's important thing to keep in mind. Yeah, that it doesn't necessarily mean you got to call the police who will take the person against their will to a hospital. Alrighty, probably as a that may be an option if someone is at imminent risk, they're going to do it at any moment, or they've attempted and you've seen the attempt, they were trying and you stopped them, and they refuse to be evaluated, yeah, or to receive any treatment, you may have to go for the extreme, which means um, calling the police. Yeah. But there are a lot of things between that and doing nothing. Yeah, a lot of things, and you shouldn't. By the way, doing nothing is not an option when someone's at imminent risk to commit suicide. Okay, you're dealing with a human life. You got to do something. Alrighty. Um, as a general rule, it's best to do things where you involve the person. You know, um, the person making a decision and freely engaging in doing something. Yeah. So options could be it's possible that they make an appointment to see someone the next day if you think that's safe enough. And between the time you're speaking with them and they see a therapist for an evaluation, they're always with someone. Another one could be you take them right to the ER, or you take them to see a therapist or a counselor. Okay, you walk with them or go with them. Now, you don't have to. You're not sitting in a session, but you're sitting in the waiting room, or you at least you walk them to until they're in the waiting room and they're about to be seen. Yeah, so there are a lot of ways, and the more you engage the person voluntarily and they're involved in the process, the better. The other thing to keep in mind is that it is scary when we see signs of suicide, and it's a scary thing to discuss. But here's the good news is that if they are talking with you, right, or they're demonstrating the signs before you and they're talking with you now about their concerns with suicide, oddly enough, that's a good sign. Yeah, because now that you're engaged with them. Okay. The scary thing is when an individual, hides all the signs, makes it difficult for people to see, and doesn't tell anybody, or when asked, just keeps it to themselves. Yeah, that's the scary thing because you don't know what people are going to do. Yeah, but as long as they're engaged with you, yeah, there's there's hope, and there is hope, and there are things you can do, and there are many ways you can help people. And now that they're engaged with you, you've just now decreased the risk that there will be a suicide. Okay, so with that, thank you again for the privilege of your attention, and we'll speak again in the next chapter in abnormal psych. Okay, take care. Bye bye.